Let's Talk Patient Blood Management. Thanks for tuning in. Today we have a story of personal triumph leading to a passion in patient blood management. We have with us, the wonderful Dr. Diana Castro Paupério. Diana delved into patient blood management and successfully introduced it in cardiac surgery back in 2018, and her leadership in this project earned the 13th Good Practices in Health Award for its significant impact in healthcare. Diana actively engages in national and international conferences on PBM, and we're just so happy to see her everywhere, delivering lectures in Portuguese hospitals to advocate its implementation. The Pandemic Patient Blood Management Program initiative received recognition in the Beyond the Call of Duty for COVID-19 Recognition Program by the International Hospital Federation. In 2021, she established a network to support PBM adoption in other Portuguese healthcare facilities, collaborating closely with ULSGE on the PBM TIPS project, tailoring the implementation in the Portuguese health system. And I'd love to hear more about that. In 2023, Diana led the creation of the book Efficient Patient Blood Management in Portugal and secured the top position in research grant allocation from the Egas Moniz Clinical Academic Center for the PBM TIPS project. By 2024, she founded the first multidisciplinary PBM clinic, winning the More Value in Health Award. Through the ULSGE's Multidisciplinary Clinics 360 project, wherein her contribution was pivotal in establishing the clinic. Diana emphasizes the importance of international collaboration in advancing PBM and maintains active partnerships with Brazil and Spain. Diana, we're so happy to have you here. And hello there, Sarah. Sarah's here today too.
Hi, Diana. It's so great to have you. And just thank you for all of your support for not only our podcast, but all that you're doing to drive patient blood management. That's quite an impressive bio. You've been busy the last few years.
Yeah. Thank you so much. Thank you for the invitation to be here. I'm very proud, and I believe that what you're doing, it's giving voice to PBM, and that's what we need to do 360 days a year. Thank you so much.
Absolutely. And Diana, we're just so impressed and so proud of you. So honored to have you as a friend. We're just floored by all of this that you've just been doing. You've been pushing through and implementing PBM and helping people to recognize it. How did you even get started in patient blood management?
I was never designated to do it. It was I found the need in my daily practice because I'm anesthesiologist. Mainly, I work in the cardiac surgery department. So, okay, over there you have a lot of bleeding issues, but at the beginning, for me, anemia was not a problem. It was like a normal condition for my patients, and we started thinking, as an anesthesiologist, you have access to your patient sometimes in the preoperative period, but in the majority of them, after they are discharged from the hospital, you lose contact with the patient. You don't know if what meant to the patient all your efforts to maintain kidney function, to improve brain health, or to support all the organs during surgery. And I don't know, as an anesthesiologist, what was the impact of my procedures, of my decisions in the patient's health? And at the beginning, we were looking at these outcomes. We were applying quality of life tests, and we were pretty impressed because we realized that we have 60% of our patients were moderately or severe depression syndromes affecting the quality of life. And if you realize all the efforts we made with transesophageal echocardiography during surgery, putting patients on ECMO sometimes, giving them advanced life support, all the all the efforts and all the wonderful surgical techniques, all the valves that are replaced, all the bypass that I made. And then I was not expecting that the patients were not feeling well after surgery. The heart is good, the kidneys are okay, but the quality of life was not as good as we expected. And at this point, maybe we were between 2010 and 2014. One of the main reasons linked to depression syndromes after surgery was preoperative anemia. And this was the first time we realized that maybe anemia is an issue, not a normal condition. Maybe we can do something about it. And all the work that Australia was doing, and in the United States, Englewood and Denton Cooley were doing, all the work that was being developed called our attention, because now we realized that anemia was an issue. Then I had some personal issues over here, because I had 2 kids in 2014 and 2016. So when I looked to this subject again in 2017-18, we had for the first time the national guidelines to implement patient blood management in elective surgery. So, okay, I realized that anemia was an issue. Now we have this national law that says that every patient submitted to elective surgery should go through the journey of patient blood management. So let's do it. Let's do it. And that's how we started looking at PBM. It's not we were not designated to do it, but we felt the need to do it.
And so since that time, you've been pretty active in Portugal. So you really didn't have a framework. How did you know where to start?
I didn't.
Your patient blood management. And tell us a little bit about the role that you have played now in advancing patient blood management in Portugal.
The most difficult, I never realized, once you have a guideline, once you have all the evidence made up, I never thought that could be so difficult to go beyond the paper. Okay, let's translate this guideline into practice. And this is the most difficult part of patient blood management, is because what works for me may be different from what works for you. And all this change, it really, we have to reinvent our way of working. Because as an anesthesiologist, I'm used to work in a team, but alone. You only have, in Portugal at least, you only have one anesthesiologist in the operating room. Okay, we work with the surgeons, with the nurses, with the perfusionists, but I'm alone as an anesthesiologist. I have my guidelines, I have my decisions. And then I start noticing that to do PBM, I had to improve my communication with the surgeons. And then I had to make good plans with the perfusion team. And then even that I don't know how do you call it in America, but we have operational assistants that they can wash your operating room, or they can go to the pharmacy, get your products. And even the communication with them, okay, this is emergent, you must do this fast. They realizing the importance of what they are doing. We truly started working only in this cardiac operating room more as a team. The communication improved. And there is this checklist that one of our surgeons gave me when I was talking to him about PBM. He went to, I believe that he went to Papworth or was talking with someone from Papworth, and they have this bleeding checklist before they close the patient, if they have to see all the potential bleeding spots and they have to say it loud and go through the checklists. And we were looking at that checklist and improving our communication. And okay, it was really important. But when you want to do PBM beyond elective patient, beyond cardiac surgery, you start realizing that, okay, but PBM is not only for cardiac surgery and not only for elective patients. And then at some point you can ask me, okay, but what made you go through in front and invest your efforts in PBM implementation? I can share with you my experience as a female, as a mother, as a patient, because when you read about iron deficiency and you read about anemia, there are a lot of symptoms that the majority of us, I believe, we have. I was a mother for I'm a mother of four, and but that time the youngest ones were quite small. They were 2 to 3 years, and the other one was 4, so very small ones. And I was always feeling tired. My memory is not the same, and sometimes I forgot to buy something or I forgot what I was going to do. I was not sleeping well, and I was always tired. And also my husband was always telling me, you must work less. You shouldn't work so hard because you are always tired. And yes, I was always feeling tired. When I was reading, I said, okay, this is me, this is me, this is me. This looks like me. In Portugal, we have this quote, like a traditional quote. You say, you must taste your own poison. So if I'm trying to do PBM and trying to apply PBM to my patient, so I will apply it to myself. Let's see my iron storages. And I had some issues after the last pregnancy. I had some issues. So for me, they were not important. And for everyone else, these issues were not important. I look healthy. I was tired, but I was not looking sick. So, but okay. PBM says I had to check my iron status, and I have to respect all the bleeding issues that I can have, and they are not normal. They are only normal if if I exclude everything else. And by that time, while I was applying PBM to myself, I was diagnosed with an early stage colon carcinoma. So that for me was the game changer, because I was feeling tired, but I was not sick. But after PBM, after studying PBM and applying PBM to myself, I could manage to achieve this biggest award I could. Even from all the awards you can give me in PBM, like the last one or the first one, this was the most important one, because in 2 weeks I will be 5 years free from cancer. And so this is if you ask me why I still promote PBM implementation and are always advocating that PBM should be the standard, it's because I'm the first patient I know that PBM, I can say PBM saves lives, as all the other people say, okay, give blood, that blood saves lives. I can tell you that PBM saves lives because it saved mine. So, and I have so many other patients like me. I have many Dianas in my agenda now, and that's why I'm so passionate about it.
I think that message is so clear in patient blood management, and that these symptoms seem vague and could easily be missed. And especially something like colon cancer, usually when you have enough symptoms to go and investigate, you're in very advanced stages. And so I really appreciated our last guest, Dr. Vernon Lau, who raised that same point, that if you have any bleeding, any small amount of bleeding that you cannot explain, or symptoms of tiredness, or any symptoms of anemia, or if anemia pops up, it's important for a physician to not just say, you have anemia, let's give you iron. No, you have an anemia, we need to find out the cause. That is patient blood management, is finding
Yes.
out that cause. And in this case, it saved your life.
Yes. I don't have family history. I was 41 at the time, so I was not in the age for screening.
Right.
So when I had the symptoms of that cancer, it could be too late, or at least the treatments would be more invasive than what I had to do. And I'm so much grateful to patient blood management, and that's why many people sometimes don't understand why I get so mad when I say, no, you are only do Facebook maneuvers to your patients if you improve hemoglobin status only. You should go and investigate what's the cause of the anemia, because this is a big issue, because it's very, you overload your doctors with work if you do all the anemia investigation. But we should reinvent the way we are doing it, and if you work, we work as a team.
Mm-hmm.
I don't have to do all the job. We just have to decide who is going to do which task, and a little bit to everyone, and you can design the journey, and the patient can have access to all of the good and gold standards of PBM. If we share with them, just don't get stuck in one medical specialty. This is not only for surgical patients. This is not only for blood banks who struggle with shortage of blood donors. This is about blood health, and this is why I'm so passionate about it.
Yeah, it's so much better of an outcome for a patient when you have those steps in place and everybody knows what the expectation is, what you ought to be doing with them. Because with so many patients, it can get so busy and we just kind of, brush off. So having a plan in place, letting everyone know what needs to be done with each and every single patient is a really great approach. Is that part of the implementation in the Portuguese health system? Is that how you're planning on a larger scale?
When I started PBM implementation, I start asking help from all other professionals from other hospitals that were doing some different tasks of PBM implementation. I went to Lisbon. There is this great immunohemotherapist over there, Dr. Susana Favoreiro. She was doing an outstanding work with the viscoelastic test in cardiac surgery. I went there, and we started exchanging ideas about how to implement, to bring it to the north of Portugal, how to start doing it. And then I was asking Professor Rubalo. He was the main guy when you thought about patient blood management, about bleeding issues. He gave this great lecture, so we went and asked his help. Whenever we didn't have answers in Portugal, okay, let's send emails. That's how I found Sam. I was sending emails to Cherry and then to Carolyn, and I was asking help from Donna Chpa. Professor Chpa helped me with anemia protocol, because there are a lot of issues when you decide, when you study the guidelines of PBM. and then you translate them into practice, it's you have to find solutions, and the solutions are not are different solutions, sometimes a little bit out of the box, when you compare your business as usual, and then what you are aiming to do. And Professor Spa, we never met each other before, and for 2 years he was sending me, I was asking him, oh, please let me know how should I do this better, and he send me his protocol. Okay, now I have this doubt, and he was giving the answer. And only in Greece last year I had the chance to say thank you in person,
Oh,
and to show the result of his support, because none of these people, they ask nothing. They are volunteers in helping the world implementing
yeah.
PBM.
Yep.
And I believe that for them to realize that the time they spend helping others, okay, the result was great. And so I had the chance to say thank you to all of them. There is this one guy, great guy, I never had the chance to say thank you, Professor Gombots. I never had, I was starting implementing PBM, and we have this national lecture about PBM implementation. He hugged me and said, okay, Portugal found this champion. I never heard the term champion, PBM champion. For 2 years, we were exchanging emails, and but I never had the chance to say, okay, what you told me about. He was the one who was always telling me, go through anemia. Don't improve only the hemoglobin level. Look at anemia as a disease. See why the patient is anemic. Not all the anemias are chronic deficiency anemias, or if they are iron deficiency, see if they are losing. Do the protocol or investigation of the cause of the anemia. And I never had the chance to say thank you so.
Oh,
Mm. So I really want our audience to take note of this important point. So I'm going to just speak directly to the audience that if you go to your physician for anemia and we give you IV iron and we correct that anemia, we have done very little for you unless we can tell you what's causing your anemia and go after the cause of your anemia. If we only correct the anemia one time, you're going to feel better, but you'll be back. You'll be back. You'll still be in the cycle where if we don't fix the cause, you're still
yeah.
going to be suffering from anemia. So make sure, ask your physicians. Don't be okay with just fixing the anemia one time. Ask, why am I becoming anemic? And what can we do to fix that?
And prevent.
Yes.
Yeah. So, Diana, you had talked to us earlier about viscoelastic testing. Is that widely used in Portugal? And what? Tell us a little bit about the viscoelastic testing, like what it is, how it's good for the patient, and whether or not you use it there.
We are a very small country. You can go from one side of the country to the other side of the country in 7 hours or something like that. So we are a very small country. But we have different realities. You have the north part of Portugal, where I live and work, and then you have the rest of the Portugal and some islands. In the north of Portugal, viscoelastic tests were not a reality, and mainly because of lack of awareness. I believe this is a big issue. And the other aspect is that because people face it like expensive. You have this is a point of care device you can have at the bedside. And the difference when we start using it is that before there are two eras in cardiac surgery. in my department and in every department that start using viscoelastic tests. Before viscoelastic tests, you use conventional lab tests, and okay, they are important. You have a delayed snapshot of the coagulation status of your patient, and you are only looking, if we consider what Tomas Kroshimor published last month, you are only looking to 3 or 5% of all the hemostatic function of your patient if you only look to conventional lab tests. As this snapshot is delayed, in the majority of time, you have to make decisions based on your beliefs in your practice. So I expect that a septic patient, like a patient with endocarditis, has some bleeding issues. The platelets will be dysfunctional. So before weaning bypass, and in order to buy time, I start calling to the blood bank and ask for plasma because I know the patient will bleed, and asking for platelets because I know they will be dysfunctional because of the septic condition of the patient. You know, it's something you believe in your practical, okay, and your practice. It's important, but this is the way we are teaching ourselves and teaching each other and passing the message if we don't use viscoelastic tests, because the conventional tests, they take too long to give us the results, and you just have to decide, and you think like that. This is our mental frame. After implementing viscoelastic tests, the only thing I realize is that I never know what to expect because every patient is different from the other. And using viscoelastic tests, I can have this quick, immediate picture of the actual hemostatic function of my patient. And in the majority of the patients, it's a not to do algorithm. When I give lectures to my residents, or if someone asks me to do a lecture with practical clinical scenarios, it's always very difficult to me to have this great scenario where I had to give all like platelets and fibrinogen and for factor PCC. It's very difficult to find a case because if you are acting in what the patient really needs, in the majority of the patients, I will say it's fibrinogen. And after that, I can tell you that Ivo Beverina last week published his experience, and he reported a reduction in about 80% reduction in fresh frozen plasma consumption after viscoelastic tests implementation in cardiac surgery. And I can tell you that this is the number we have in mind that we will achieve 80% reduction, because we are not working based in our beliefs, but in what actually the patient needs. You can see with viscoelastic tests, the clot formation, the clot firmness, the clot stability, and then the lysis. You can analyze everything. Okay, there are some gray areas, but we are talking about 5% of coagulation assessment with conventional lab tests, and perhaps 5% missing in ROTEM. It's what I use. So this is completely change our practice. And now I say that empirically, I cannot decide anything because I don't know how the patient, and the majority of patients that I was afraid that they will bleed, with viscoelastic tests, I'm sure that they are in a bigger risk of clotting. not bleeding.
That is amazing.
It is amazing. It's such a good test because it helps to make better use of the products for the patients, which is, to me, very respectful of the donors that
Yes.
are out there giving their own blood to these patients. So we want to respect the products that we have as well as we can. And it's by only giving what's appropriate, it's better for the patient, right? So yeah, it's a wonderful test if you have the luxury of being able to use any type of viscoelastic testing. And I'm smiling because all these names that you mentioned, we're so lucky in patient blood management to have all these wonderful people. Thomas Crochmore and Ivo Beverina, just so many phenomenal people in patient blood management who are so intelligent and so patient focused. I love it.
What I feel, and I'm an anesthesiologist, and I'm, I w- was interested in other aspects of anesthesia, but I never found international experts so willing to help
Mm-hmm.
Yes.
as it's incomparable. Klaus Gorlinger, he's the guy, and
Yes.
he
Klaus.
came to my hospital, and for 2 or 3 times we sit and show him our sometimes not so difficult scenarios, but the ones that are changing our practice, just for him to validate our decisions. Okay, so Dr. Klaus, please look at this scenario. This was an aortic dissection. Before ROTEM, I believe that we were asking for 5 units of fresh frozen plasma and 2 pool of platelets. And now I'm looking at these results, and I don't have to do anything. And it's not comfortable because, and if the patient bleeds, but I'm seeing that the coagulation status of the patient, it's normal. So, but it's not comfortable because it's so different from what were doing.
We're taught.
And he validates, and sometimes we do just, okay, but let me just do something. I'm not comfortable of not doing anything because we used to do so many things. And he gave us the confidence and validates and supports. This is completely outstanding. How you have international experts, they are not in the Olimpo. They are next to us, helping us. And this is, for me, it's the first time I have in medicine. So thank you, PBM, and thank you all of you guys.
It is so true. I think that if you've practiced in other specialties, a lot of things are proprietary, right? And so people will not share how they have implemented the science because it's important to them because they somehow want to be special. But in patient blood management, it's really the first specialty. And I think it's because it is so multidisciplinary that we do need all of the disciplines, that the sharing is phenomenal, right? They just want it to benefit people globally,
Mm-hmm.
and they are so willing to share their knowledge. I think that is true. The
Yes.
thought that you shared about how if you're only using conventional lab tests, you are treating a patient based on just your beliefs. I had never really thought about that before. And how with the viscoelastic testing, you're treating the patient based on what you absolutely know
The patient needs.
the patient's needs at that moment in time. It Viscoelastic testing is so powerful, and we often here in the United States see it in the cardiac surgery realm, but it's got applications for many other realms, trauma, critical care. Where are you utilizing it?
I'm very I will give you the correct picture of what is happening in my hospital. I know there are many hospitals in Portugal that are using ROTEM in cardiac surgery, but maybe you have Rotem, but you can't, you don't have the pathway to optimize the patients in the preoperative period. So you have one aspect of PBM, but it misses all the others. Then you have some hospitals that are, okay, they are doing a wonderful job with PPH in the obstetric ward, but okay, then they miss, okay, like the use of saver or something like that. So in my hospital and in the north of Portugal, that is the reality I know best, because it's the majority of the people that asks me for help. I can tell you that we are disseminating the implementation of viscoelastic tests in cardiac surgery. And now I can say that penetration in daily practice in my hospital goes around 50% of the patients. Maybe this is the objective. The patients that really have indication for ROTEM maybe can be 50% of the patients. But for educational purposes, my ambition at the beginning is to use ROTEM in 100% of the patients that are on a bypass, cardiac bypass. Because if you don't do this at the beginning, you maintain old practices. Okay, we are 3 hours on bypass. Let's ask for fresh boson plasma. Then we'll do the ROTEM later just to see if we need anything else. So at the beginning, to change the way you are working, we mainly in patients on cardiac bypass, you should do urotem to all of them. And then when you change your practice, then, okay, if it's a short bypass period, maybe you don't have to use urotem. But at the beginning, to change old practice, we should do it. So even in cardiac surgery, we have a long way to go, a big margin of improvement. We are starting introducing PBM in emergency room and all in the emergency department, and also in the intensive care unit to critical patients. This passion about it came from what we were seeing in our critical patients in cardiac surgery, because from all the patients we were expecting them to bleed. The biggest problem for them was thrombosis. So we were contaminating the intensive care doctors, the intensive care team, and they are completely involved. They are passionate about it now. And we are, as with tips, that we are bringing all the hospitals that want to do something together in order to do it in an easier way and sharing knowledge. We are building this intensive care team to share, to implement, to help each other in the protocol. And Tomas from Brazil is helping the team. He gave us already lectures, and we'll change difficult scenarios. We are do also the trauma protocol using viscoelastic tests. The last step was the implementation of viscoelastic tests in obstetrics. And there we have Fatima Khatun from Qatar. She is an amazing anesthesiologist, and she has so many. I believe I have to ask her again, because I still don't believe that she has 20,000 births per year. So in my hospital, we have 2,000.
Right.
What for me happens once a month, for her, it's twice a day. So
Wow.
she has a lot of experience, and she's helping us in this practical implementation pearls in order to give us more confidence to implement. And we are starting and sharing with everyone that wants to go with us. We just share it and just go together.
Fantastic.
Sounds like there's a lot of positivity in this movement. Have you seen a lot of good outcomes? Do you have any outcomes you'd like to share with us?
As a doctor, I didn't learn how to build a business case or to
Mm-hmm.
to have to prove everything that I'm doing. My proof is okay. My patient is it's good. Result is good. The
Right.
patient is happy. He was discharged from the hospital, so that's the way to go. With PBM, I had to change the way I work. We all we are always proving the benefit for patients, the benefit for institutions, the benefit for the global health. We are always proving the potential of patient blood management, and this modifies the way that you are working. So at the beginning, it was very important to show the short term wins, the reduction in RBC. In 2018, before PBM, our annual consumption of RBCs were 1,100 units. Now, and this is for elective, urgent, and emergent surgeries, the global consumption of the department. And now we are using 600. So from 1,100 to 600, this is impressive.
Very.
But when we look to the target hemoglobin levels or the triggers that led to the decision of transfusing, I can say that we will be very comfortable in maybe 2-3 years in only using 300 units per year, because we can achieve in a bigger reduction when we improve education and all this positive feedback. Okay,
Mm-hmm.
we achieved this reduction. Our patients, the length of stay was reduced in 2 days. We even with the viscoelastic tests that the cartridge, okay, you say the cartridge is expensive, but we reduced the fresh frozen plasma consumption. Patients are less time on the ventilator, less time in the intensive care unit, and so and we are going, this is the short-term wins, and then you just go a little you give another step, and now we are looking at the outcomes at 90 days, and we see that these patients return less to the hospital, return less to the emergency department, they have less infections after discharge. And so if we are making all the money counts around this, if we were looking at discharge, only at discharge, we were saving 3,000 euros per patient. And now that we are going a little bit further from the patients that were anemic from the beginning, the optimization period, all the journey in the perioperative period, and looking what happened to them at 90 days after discharge, the savings are 16,000 euros. So per patient,
16,000
16 now
euros.
per
Oh, wow.
patient.
Wow.
So, and now we are aiming to go until 1 year after surgery, because
Mm.
we have to prove. And, when you have, for many hospitals, viscoelastic test is reality, so they don't have to prove anything. But when you are asked to prove the
Mm-hmm.
benefits of it, it's good to have all this data and say, okay, let me spend 100, 200 euros in a cartridge because you will save 16,000 euros. So you have
Yeah.
to, you must have this data. And also to look, we must help not only the global status of our population, but we also help the sustainability of our system. In
Mm-hmm.
Portugal, the majority of the public health and all the health system, it's public. What you pay for all the procedure, it's it's free. The public system that pays for your treatments. So you have to look to the sustainability of this all this
Right.
process. And PBM it's good for everyone.
I'm still just reeling from the thought of, as a patient, I would want to be treated not by what my physician believes, but what they know. So that point you've made is just, it's really sticking with me. And, all physicians do their best. And sometimes
Yes.
they do treat on what they believe. That it's a part of their practice and it's intuitive, but if they can know and treat to that, boy, what a difference that makes. I'm sure every patient around the world wants that. So in thinking about what message you would like the listeners to take away today, what do you want people who have listened to your story and listened to your experiences in Portugal, what would you like to send them away with as a final message?
As a final message for different audience, for doctors, I would like them to open their minds to multidisciplinary and multi-professional work. This is the key to achieve success in PBM implementation. For nurses, in Portugal, we underestimate the value of nurses. And I believe that they will be a good answer. They will be a key to the success of PBM implementation in Portugal, because we sure need help. And when you look at the quality of life, the social dimension, global health status, preventive medicine, screenings, I think of the role of the nurse. Also for perfusionists, I believe that that if we work as a team, they can give a great contribution to PBM implementation. So these were the three main classes of healthcare workers, which I would like to call to action to work together in PBM implementation. And then you have the whole population that can hear this podcast. And what I would like to share is that, okay, you have to trust your doctor, your nurse. By the end, when they go on strike, when they are struggling to achieve better conditions to work better and to treat you better, stand by them. And if they are not doing better, maybe they don't have the right conditions to do it. So stand by them. And sometimes knowing your rights, it's the best way to help your doctor, fighting also for your rights. Because at the end, if the patient says, I want to be treated like that, okay, we'll be two saying the same. You have the rights and you have to ask for it.
Very important message. Thank you so much for sitting down and talking with us today. And I hope that you'll certainly have a conversation with us again in the future.
Thank you so much, my friends. It was a pleasure.
We hope you enjoyed this conversation and found some takeaway or new thought that improves your health. We would love to hear from you. Feel free to reach out to us on our website if you'd like to see what we're up to. Our website is letstalkpbm.com. If you enjoy our conversations, please like and subscribe wherever you listen to podcasts and on our YouTube channel.
Special thanks to our guest and our producer, Delaney Coronado, and the entire production team for all of their expertise in content creation, technical abilities, and dedication to our message. We appreciate the experts who drive this medical movement forward, and our affiliate partnerships who support the work that we are doing. Until next time, stay connected to your blood health.